Okay. So, last but not least, Dr. Steve Hollenberg, a leader in our field from Emory, is going to talk to us about Just Say Yes to Shock, feasibility of accepting all patients to the hub center. I never heard this Just Say Yes.
Yeah, so I thank Marwan for giving me such an easy topic. I should start. I have nothing to disclose. You'll see this slide. Telly is 2. Who is Telly? Anybody who knows me, this is the cutest little mini sheepadoodle ever. So I thought about this talk. It's sort of, I'm really glad to be invited to the Houston Shock Symposium. It's a great meeting. And I thought, how can I give a talk without showing a pressure volume loop? But I really wanted you all to be awake, so we're not going to do that. And I thought about giving you data about yes and transfers and this and that, but it's really all local. So I think I'm just going to talk through this. And I want to talk about just what the forces are pushing you in this way and what the forces are pushing back. So who wants you to admit the patient? The sending physician and the facility wants you to admit the patient. The patient and the family want to go to the center. The sending physician has said your best care is at the referring, we want to refer you to the better center. The head of your shock team is running the shock team. They want to get the patients. That's what they're all about. The head of your heart institute has a shock program and they want you to take patients. And in fact, as we just heard, the chief financial officer wants you to take the patients into your bed. Great, everybody's all on the same page. So now let's talk about what do you need to accept the patient from the other hospital? You need a bed. You need a staffed bed with a nurse. Your unit is always full, but you have the patient in bed 4, and you say, great, I'm going to send the patient to bed 4 who's fine, and then I'm going to take this patient from wherever. But they need to give you a bed. They just told you the hospital's full. I don't have a bed for the patient who needs to be transferred out. So you need that. The patient is out somewhere else. You need transportation for that patient to bring the patient from where they are to where you are. And then you need mobilization of the shock team when you get there. So this is what you need. And then this is the problem, or at least it's the issue. This is what you have control of. You have control of the patients in your unit, right? And you have to control the decision to transfer one out. I got the patient in bed 4. This person's going out so I can find the bed. And you have control of communication with the shock team and the sending facility. You talk to them, what are you sending me, what are you doing, et cetera, et cetera. But there's stuff that you don't have control of, and this is where the challenges come. You really don't have control of everything else. You don't have control of bed availability outside the CCU. You don't have control of the people in the hospital. You don't have control of what's going on in the ED and what they're talking about getting the patients out of the ED into those open beds in the rest of your hospital. So you don't have any control over what's going on there. And again, your hospital is local. It's got to worry about the ED. They got patients in your ED. They're lined up and this and that. They want them out of the ED, et cetera, et cetera, et cetera. And at least in my situation, you don't have control of the transport. This gets to be a little bit of a challenge. It turns out that at least much of the time, the transporters that we use spend their days transporting people during the day to various places. And when they finish that at 5 or 6 o'clock, then they can start transporting people from 200 miles away to your hospital. So when you get the call at 9 o'clock and you say, great, send them over, we've got an open bed. 6 hours later, you're going, where's the patient? They're only 50 miles away. Well, the transport, et cetera. It can be a challenge. So you can say yes, but you can't guarantee that there will be a timely transfer unless you always have a bed and a nurse and a timely transport mechanism that you control. If you've got those things, then you really can do that. So there are challenges even with this. Keeping an open bed has costs. Some people might not like it. Who might not like it? People who are holding somebody waiting for an ICU bed in your emergency department. The people in your hospital who are charged with efficient bed utilization, right? We want, 99% utilization. How am I holding an open bed for 6 hours in an ICU when I could fill it in 6 minutes if I had to? And the people who have to flex up staffing at short notice. Oh, by the way, you have an open bed, but I'm about to take a patient, put them on, and put an Impella in. You're going to need one-to-one nursing, et cetera. And as I've sort of alluded to, if you don't want to rely on somebody else for transportation, and our system does, then you have to do it yourself. And doing it yourself means then you have another system, you have a transport system, and you have an administrator trying to figure out whether this transport system is making money. And whether are they exist only to transfer shock patients into your ICU? No, they're doing this, they're doing that, they're doing this, they're doing that. And then every once in a while, their priorities are somewhat different than taking this patient into your ICU now. And the other challenges are, you get them from the other hospital, you get the best information of the people there. Sometimes the patient might not be as sick as billed. Right? They say they're very, very sick, and they come, you say, well, really? I jumped, I knocked myself out to take this person. They have atrial fibrillation with a rapid response, and the blood pressure is 80. That's not shock. I gave them a little bit of fluid, this and that. And actually, sometimes they might get better while they're waiting. They're doing something, and by the time they get to you, they're better, but they don't bother to call you back and say, never mind, or this doesn't need the unit. They say, look, they gave me a bed. We're going to put him in the ambulance. We're going to send him to you. If it doesn't need your unit, you'll deal with it when you get there. And you will. You'll say, great, can I have a bed on the floor? Oh, no, sorry. And sometimes they actually, and you get the other side. Sometimes they might be sicker. They might be sicker because they're not realizing at the sending hospital how sick they are. They might be sicker because while they're waiting for the transport, they're getting sicker and sicker, either because of what they're doing or because the plan from the minute you accept the patient is transfer, transfer, transfer. What are we going to do about this oxygen? I don't know. But they'll figure it out when they transfer them. Sometimes that works, sometimes it doesn't. So this is a perfect segue from what Ray Lau just told you. Start with the why. It's good for the program. It's good for the shock program. That's why we exist. We don't exist just to serve the patients that live 2 miles away and show up in our ED. We serve the community. We're the core hospital. We're the hub serving the spokes. It's good for the institution. Whether that's good as the hub hospital for a hospital system that you control. You have 8 hospitals, and they say the level 1 ICU, level 1 CCU is going to take care of all these patients. And most importantly, it's good for the patient. The patient is going to get better care in your carefully designed shock system than they otherwise would have gotten. What can you do? Well, if you can land the patient somewhere other than the ICU if you have to. Even the option of doing that allows you to say yes and sort it out while things are being put in place. So if I have to have an open ICU bed, that means I have to get the patient out to the other, and I have to have a clean bed, et cetera, et cetera, et cetera. If I got someplace else to put it, then I can say yes and sort it out while the transport's being arranged. Have a plan for transportation if you can, and as other have mentioned, garner support from the administration. They need to understand what they're doing. They need to understand why it's important for your shock program, for your institution, and for the patients that you're serving whose outcomes will be better. So, in conclusion, just saying yes, not so hard. Backing it up, not so easy. Thank you very much.
Thank you. That was really good. So this is open now to the audience and to the panel for questions, comments.
So Steve, that was great. It's interesting. That was actually one of the things when you were on a committee when we designed SCI classification was exactly that problem, that they're either too well or too sick and not as advertised. So maybe we're a little closer, but do you go over a checklist when you ask patients to get, or do you just say, yeah, tell me the bullet? And I find sometimes if I ask too many questions, they get hesitant to send.
Yeah, I personally, there's individual variability. Given it depends, everything is local. There's so often a delay between the time you accept somebody and the time that they get there that the sort of granular information that you might ask for isn't really all that helpful you'd like to know what you're getting. You'd like to have some idea who you might have to mobilize when they get there. And at some level, you'd like to know that they're not sending you a patient who's 105 years old with 9 forms of cancer that you really aren't going to be able to do anything about. Or alternatively, that the blood pressure, the systolic pressure is 50 right now, and they're really not stable enough to go to transfer. But after that, I tend to say, let's see what they look like when they get here. And to some extent, that means not calling my surgeon and saying, oh, by the way, sometime between 2 and 12 hours from now, some patient is going to show up who might need something or might not need something. In general, you land them in your unit, you sort them out quickly, and then you go from there.
You know, Steve, you and I have bemoaned this over drinks many times, and
Yeah.
I think one of the issues is we all think our patients are the sickest patients, which they are. And then we deal with, we have a couple of helicopters, a couple of critical care staffed ambulances, but then I have to share them with the stroke program because there's a stroke out in our community, and then there's a trauma out in the community that's being brought in, and you know, there's a MICU patient that's sitting out somewhere that's needs to go on VV ECMO, and they need to come in. So sometimes in the middle of the night, even though we have some resources, we never have enough.
Yeah, I think that's right. I think that's why that makes
Laura,
it so
and then we'll
complicated.
go to the audience.
So I was just going to say, we are a hub now. We used to be a spoke, and now we're a hub, so we've grown and grown. And one of the things we've utilized when we are backing up for beds is we put patients that we could transfer out of CV ICU into our CV kind of PACU area and put one of the APPs down there with them to open up a bed for the patient to come from an outside facility until that bed can open on the floor to move the patient out of there. So it does take one of our APPs out of circulation because they have to stay on the floor with those, on the PACU with those patients. But it is an option for if you're in a pinch and you're trying to open a bed.
I agree with that. I wish we could do that. PACUs are a little prickly sometimes. There are some PACUs that are embracing and some PACUs that are not. And it depends a little bit on how your PACU is staffed. So making your PACU stay open for another 4 hours where they wouldn't otherwise, when now they have to staff it with other people
No,
to
we
APP or not. But
we send an ICU nurse down with them. It's one of the ICU nurses.
right, but it has to stay open, and the pharmacy and
And that means you have an ICU nurse to send.
That's right.
yeah,
That's the
yeah.
hard part, too.
It's perfectly good. It's a perfectly good suggestion. I wish we could do it.
Please introduce yourself. We have the lights and we can see.
No, this is Arvind.
Oh, Arvind.
Yes. Steve, thank you. I think you hit really on some of the practical issues we run into. I have 2 questions. One is I've kind of started to envision this not as a spoken hub, more as a network, because you have to then invest in the referring hospitals, because no matter how much we try, there will be a lag time in the perfect world. And what that opens up is a little bit of an implications on incentives to invest in the referring system so that they can maintain the shock patients up to an extent they can come over. And then the next question becomes, has anybody had experience in providing telehealth guidance, and what are the legal implications of not having privileges in a local place? And we've kind of been discussing that, but I don't have answers. I don't know if anybody has any experience.
Yeah, I'll give you a little bit of take on that. So I take your point about the network. I would point out that there are sort of 2 sorts of things. So Emory has an 8-hospital network. So if you're in our 8-hospital network, then the idea of investing resources so that patients who are already in our network get care is good. But Emory also, Georgia is a big place. There are counties who have 2 cardiologists in the whole county and a little hospital. And those hospitals are really not ready to do that. And we take those patients off their hands. But in terms of organizing, probably the best thing to do with those people is scoop and run if we can. Again, the scoop and run is a challenge with transportation and whatever, but that system outside with the 50 little tiny hospitals that we're trying to serve, that's probably best as scoop and run. And so tele ICU is another challenge. So Emory does have a fairly robust tele ICU program. I would say that you don't really want to be taking care of a patient that you can't see unless you already have a relationship. So one of my pet peeves is to get a call from an emergency department 250 miles away, and they say, we'd like to transfer the patient. I say, sure, we will take, yes, glad to have them, but I've got 3 other requests. This might be a while. What's your backup plan? Why don't you put them in your little tiny ICU? They said, well, we called the ICU. They said to call you. Then you say, I'm not your ICU. I'm 250 miles away. Your ICU is your ICU. You need to put them there, and then we will try to take them from your ICU. So if I have tele-ICU in that ICU from my tele-ICU docs, then I really can help you in your ICU. So I do think we need to try to organize systems in those outside hospitals, but if we're talking tele-ICU, I think you're already going to have something set up in those hospitals, and maybe they should invest in that and let you get your tele-ICU fingers out there.
And I couldn't agree more. And the co-management model, and I don't think, as long as you have relationships, Arvin, the legal is not going to be an issue because they will manage the patient. They're not going to say that you told them to do that, right? I mean, it's co-management, and you are collaborating with your colleagues that you already built relationships over the years by visiting there frequently or visiting, having them visit you. So that's how we do it, 250 miles, 500 miles, or even more than that, through the map that we showed earlier. Please.
Steve, your talk is a perfect example of the guiding principles of triage. There's room for the bears, there's room for the bulls, but there ain't no room for the hogs.
Well said. Okay, so thank you so much. Phyllis, we will have Q&A after this. We need to wrap it up.
They know.
We need to wrap it up. Thank you so much, everybody. Excellent, Steve. Bye.
Thank you, everyone. Refreshments in the exhibit hall. Our program continues here at 10 a.m. Thank you.